Welcome, everyone. Uh, I'm Anil Garg at MRCPCH Clinicals, and this is our logo. I firmly believe in that if I tell you, you will forget. If somebody shows me, I may remember, but if somebody makes me do it, I will learn. And the next line, which is not added, is that if you really want to make it stick in your mind, then you go and teach. MRCPCH clinical examinations and MRCPCH online. I'm based in Worthing, and we are talking about the clinical examen from next year. So, in the clinical exam, you have the talking stations and the doing stations. And as it shows, talking stations are focused history and management, in which you would have to take a history and then discuss the implications and management with your examiner. Communication, which is again talking only, but with the role player. Two of those, video, in which you will see the video and then again talk about it with the examiner. There are two of those. And then there are the doing stations. There are four clinical stations of 9 minutes each, and a development and management. So here again, there is a fair bit of talking, but there is also doing, in that you'll have to do the set task in that period. You have 4 minutes between stations to change over. And this is the typical circuit of the examination. There are 12 rooms set up: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 candidates start the exam at any one point and then move forward. There'll be people there, guides to help you move from one room to the next, because sometimes the layout may be not physically next to each other. You would only be assessed in 10 stations, and that is because in history there are two stations and two candidates would go, so you'll only have one history and then again one development station. Now, a little bit about us. So I'm Anil Garg, like I mentioned. I'm in United Kingdom on the sea coast in Worthing. We have a colleague in Bangalore and another one on Kuwait. How we guide your preparation is we have the online material, in which we have the 5 online modules, which are recorded sessions of how to do the various stations as we have seen, the best practice, which will expect you to see, analytically criticize, and then adapt the best from them. Mini mock examinations are interactive sessions which we have regularly, and as you have attended some yourself, we have the rapid random reviews. And rapid randoms are 3 quick topics chosen at random, thrown at you, which make you think on the spot. We introduced this into our schedules after feedback from trainees who mentioned that when they go into the exam, when you walk into the room, you do not know what to expect. So, although you have read a lot, you have to think on your feet. We have got group exclusive membership, uh, which is being updated recently. We have one-to-one sessions which can be subscribed to if there's any specific need. Face-to-face course we used to conduct before COVID, and we are starting again now. Our next course is in January, geared for the exam in January and February in India. The face-to-face course has a mock examination for self-evaluation in which you are given formative feedback, and then we offer ongoing mentoring by our course. Now, in our last summer session, we had 75 random review topics, 25 interactive sessions, 27 episodes of Hot Seat, 40 episodes of Examiner Hats, and 2 examination updates. Now, Hot Seat is that at the mini mock exam, one of the candidates or one of the members behaves as the candidate in the exam. They are given the task and they have to confirm and complete it under examination conditions. Examiners are again either faculty or members who observe and mark the performance as per the RCPCH guidelines. And the advantage of this is that it gives you an insight into how you will be marked. If they comment on a positive or a negative, then we have to give you a reason why, as you will also get in your examination. In the examiner's mark sheet, at the back, the examiners will write why they have allotted you a certain mark. Our members have made us very proud. At the last exam, most of them passed. One was unlucky because of some error of communication in development, for which the college accepted responsibility and offer a fee refund and the next diet. We are really proud of you and we look forward to working with you. The subsequent information now is from the RCPCH website, as the exam is again moving to face, though with some changes. Communication. In my experience, communication is the most important skill. It's important for you in your life, not only in the exam, but in your general life, your relationship with patients, with community at large. Coming to the exam specifically, it is relevant across all domains. You get marked for communication in every station. Although there are two communication stations specifically, do not think that at other stations your communication skills are not being observed. They are being observed and you are being assessed. So, this, in my opinion, is the most important. You need to practice the most and will give you the maximum return. So, communications, there are two face to face stations of 9 minutes each, and there's a warning at I think 7 minutes now, not at 6. You are given a task outside to read. You go in, the examiner takes a mark sheet, introduces you to a role player, and you take it away from there. The examiner is present, but they do not interfere. I never interfered in my years of examining, and it's never really required unless the patient or the candidate is being rough with the patient. If you are being rough or being dangerous, then the examiner will stop you. Remember, communication is about information sharing and giving. It's a dialogue and not a monologue. The tasks are usually derived from your daily occurrences, and you have to discuss the implications with the role player, and it's not your agenda, it is their agenda. So we will go over that when we go in details at the communication station. Do remember, it's not a test of knowledge. Do not try and tell everything you know about the condition the moment you sit down and start talking. Remember, it is a two-way process, and if you ignore the role player or the other person, then you're digging a hole for yourself. Here, it's also important when I said you do not have to tell everything, you do not have to know everything either. If there is some bit of information you do not know, then do not guess and do not try and say something incorrect and flash over, because the examiners know when you are fibbing and when you don't know. So the thing to do is admit ignorance. Well, I really don't know about that. I will check and I'll come back to you. So checking could mean I'll look up a book, I'll look up a BNF, I'll speak to my consultant, I will speak to my registrar, whoever, and I'll come back to you. And that is a perfectly acceptable way to practice, and in fact is a better way to practice than try and fob your way through. Acknowledging ignorance is fine, but if you give wrong information, then you will be penalized. So the tasks you can get in a communication station would be information giving. So that a diagnosis has been made, you have to pass that on to the role player, some results, a care plan. Bad news, suppose a baby is born with a congenital heart disease. How will you tell the parents? Or if a child has been admitted with symptoms and signs and you diagnose leukemia or you suspect leukemia, how would you inform? So that is bad, breaking bad news. It could be dealing with professional issues. A colleague of yours has started coming late and doesn't seem interested. Or you noted a colleague of yours changing things in the notes. How would you deal with the professional issues? Critical incidents like drug error. So a baby has been given the wrong medicine or a wrong dose. How would you communicate that? A child has a respiratory arrest while you're passing a nasogastric tube. Not you specifically. Maybe the nurse was passing the nasogastric tube and the child has a respiratory arrest. How would you manage? It could be negotiation. A new drug has to be started, and how would you talk to the patient? Or in our case, the parent. It could be a teenager, so yeah, the patient itself. Somebody has come in for signs of you think is meningitis, you want to do a LP, and the parents are not happy. Most of them would be, but if they're not happy, then how would you address the issue? Education, again, speaking to a junior colleague or a nurse. Here, it's worth keeping in mind that nurses in UK have a very important role and have a different, what should I say, social authority. My experience of working in India was that nurses were sort of, the lowermost cadre along the team. But here, The ward sister or the ward nurse would be next to the consultant. The senior nurses know a lot. And if you run into a problem, it's always good to say, I will check with the sister because she will guide you. If she's saying something is not right, then take it seriously. Same happens in India, but I think it's just the social structure has not quite been updated yet. Focused history and management. It's a long station, 22 minutes, and 13 minutes with the role player and 9 minutes with the examiner. There may be a difference of a minute or two here and there, but you do not worry about that at this stage. You are provided with a brief introduction to the child's concerns and issues while you're waiting outside. And this could be something happen in the ward, something in the outpatients. And while you're waiting outside, it gives you an opportunity to put your thoughts down on a piece of paper in a systematic way as to how you would get the details. It's very important to be orderly because otherwise the examiner would write back and say, oh, wasn't consistent, jumped back and forth. So, history, present history, complaints, social history, medical history, as you would normally do. As I said earlier, it is a talking station. So, there is a lot of talking, but it's different to the communication station in that in communication station, you were giving out information. Here, it is about information gathering. So, in communication, where you will be talking more than the role player, here you expect the role player to be talking more than you. So, don't get confused. You will have leading questions, you will have open questions and closed questions. We will again discuss over the next 2 to 3 months and get you on board. This is what you normally do in your clinics, even now. So don't panic. Examples of tasks would be usually the patients will be with chronic illness, something with asthma, Crohn's disease, diabetes, epilepsy, faltering growth, food allergy. And generally, a crisis has developed in the previous 3 to 6 months. Something has happened which has prompted the patient to contact you or their general practitioner to refer them back to you or something similar. So you need to try and dig out what's happened which has precipitated the crisis. And then again, take the other details which you will practice. Acute cases are usually not given, but can be. And they are generally you have to get to the diagnoses. Histories are not that great, but there are a few which you might need to practice, and we will. In the acute case, I can recollect now is you may get information about a baby who's been admitted being unwell. Initial investigations show a serum sodium of 116. So it's probably an adrenal crisis, and you need to work that through. Clinical examination, so it's a systemic examination. There are 4 stations of 9 minutes each, and there are 4 minutes between stations for you to change over. A little bit of background information may be provided or may not necessarily be there. Usually, you will not know what is behind the door. In earlier days, uh, My experience was that on the door it was written CVS, respiratory, abdomen, other. So you were mentally prepared that, this is what I have to do. But I understand now that that information is not there. You go in, the examiner will give you a brief, very brief summary and say, please examine the child or examine the cardiovascular system or the respiratory or as the case may be. Remember, general physical examination is a part of every task you are given. So, 4 clinical stations, 4 general physical examinations. And think of it like you are sitting in the clinic and a child been referred to you by a colleague with a murmur. You'll only get to the murmur later, but first, as the child walks in, you do have a look generally what he's looking like. Oh, is he looking comfortable? Is he small? Is he dysmorphic? Is he blue? Is he pink? So that is what the general physical examination is. And then you'll move to the specifics. And it is for these things where the rapid random comes in quite handy because you have been thinking on your feet. So systems are cardiovascular, respiratory, neurology, abdomen, MSK, and other. Uh, None of these are mandatory. So you could have any 4 of these on your circuit. Video stations, there are 2 video stations and examiners are present at both. And here you will be moving from one to the other. So once you go in, you get 3 minutes to watch the video, and then you will have 6 minutes to discuss. What the college or the examiners are looking for in their marking uh, domains are identification of signs present and correct interpretation. You have seen the video, you say that these are the signs that I have noted. Differential diagnosis, so you may think that there's only one diagnosis so obvious, but my suggestion would be always try and find at least 2 or 3 possible diagnoses that you would say I would need to rule out. Then you would have the implications of clinical science that will come in the discussion with the examiner and appropriate steps to confirm the diagnosis if it's not conclusive. So in your discussions with the examiner, you'd be asked what are the relevant identified problems, a safe ethical management plan, how you may address that to the parents, and appropriate escalation. Most of you in India, especially, and in Far East, are working as consultants. But for this exam, consider yourself as a registrar, and escalation means if there is at all any doubt, speak to your senior. I will discuss it with my consultant or I'll run it past them, although I may carry on the plan. Prompts are provided to all because even if you have had a differential diagnosis of 2 or 3, or you have a specific diagnosis, the discussion is held on the same topic with every candidate. So if the rash shows Henneck-Schonlein purpura, differential could be meningococcal sepsis, could be trauma. Uh, and then the discussion with all the candidates will be HSP. even if they have not made that diagnosis. So, introduction, setting of the scene, acute illnesses, seriously ill children, children with transient signs, and neonates. And these are, as you can imagine, which cannot be brought to the examination hall. Hence, we have this, and generally, though not inevitably, there'd be one newborn and one older child. Development station is a long station in which you have again 13 minutes with the patient and rest of the time with the examiner. And think of it as etiology and functional ability. So you have to take the history, which is slightly different to the history you would take in the history station or you might take in the video or in the clinical station briefly. So you take history in your time with with the role player or the patient, and then you may be asked to assess the gross motor, fine motor, speech and language, or a development age. Developmental age means you have to look at all the domains, but very briefly, but it's unlike that you'd be asked to do a full assessment. And it can be done in the time provided. With practice, it can be definitely done. So the tasks you might get, mother is concerned about son's use of manipulation. You know, he can't feed himself properly compared to his older sibling, or he keeps dropping things. Referred by the health visitor for speech, please assess speech. Motor age, child maybe have some dysmorphic features. Parents are concerned that, oh, he's 3 years, but he's not doing what his brother or sister or his peers are doing. So you need to go back and assess that. Now, development station is still a virtual station. During COVID, when it wasn't allowed to have children in the exam, all children were taken out and we had a virtual exam. Now, the children have come back to the clinical stations, but not quite yet to the development station. And I expect that towards the end of next year, maybe they will also have children back in the development station. You are shown a small clip. It could be a video clip, photograph, video, and audio to give you a background of what the child has or what is being demonstrated. It could be a photograph of a child with Down syndrome, maybe some other abnormality, maybe a video of a child
Sir,
walking with
sorry to
hemipated gait.
disturb, sir.
Yeah,
Development is not virtual now, sir. It is face to face with role player.
no, sorry, let me just clarify that. The It is face to face, but there is no child there.
Okay, sir.
There's no children. So the history you take will be from the role player.
Okay.
Then the role player will leave.
Okay, sir.
Now, remember in the clinical station, there was a child there. You could listen to the heart, feel the abdomen, tap the knee, listen to the chest.
Yes, sir.
But in the development station, to my understanding and what the college says, there is no child.
Yeah.
So they can say 3-year old, parents are concerned about the development, please assess the developmental age. Now, you do not have a 3-year old child there.
Yes, sir.
So that is the virtual part in which you have to imagine the child is in front of you and you have to talk through how you will assess the various domains to come to a diagnosis.
Talk to the examiner, sir. You are asking like
Yeah,
that.
yeah. So you
Okay.
have to talk your examination technique to the examiner.
Okay.
Yeah. So in universal cues, again, universal and dependent cues, that is part of the history thing, is the video you have been shown or the photograph is the same to everyone. So the clues there are for everyone and they are called universal cues. But then while you are progressing and asking, that becomes the dependent cues. So can the child stand and run? Or how does he pick up? I give him a cube. Does he take it with his left hand or does he take it with his right hand? Or which is his preferred hand? So that becomes a dependent cue, right? So you have to have the universal and the dependent cues. And then at the end, you will have to give your discussion with the examiner. So coming towards the end is how we guide your preparation is we have the face-to-face course, and there are lots of face-to-face courses, but my feeling about them is that in 2 to 3 days maximum, they cannot teach you everything, they cannot monitor everything, and it only gives you like a roadmap. You have a Google app in your mind as to how I need to negotiate, but nobody is there to tell you what you're doing right, what you're doing wrong. And although important, I think you cannot only manage with a face to face course. You do need ongoing advice and suggestions, and that's where the interactive Zoom sessions, mini mock exams come in, online modules to see the best practice, how you can incorporate it into your daily practice, and especially for the exam, rapid random revisions to give you the ability to think on your feet. And then we have the WhatsApp group in which you can discuss your queries and concerns with colleagues and friends. So this is a list of like online modules for clinical stations, development, communication, video. It's too small to see, but clinical examination modules are cardiac, scars, extended clinical, communication, UTI management, information giving to a carer. And then we have the best videos recorded by one of our previous trainees who have done it very well. So that can give you a clue. Or we have the mentors or the examiners simulating a good discussion. Rapid random, you have done it, so you have an idea, but it could be tracheoesophageal fistula. A baby is mucousy at birth. How would you manage? So my advice is take 10 seconds to think before speaking in the exam. Same here, 10 seconds to think, and then you give out the basics. So you get the opportunity to talk about it for about 2 to 3 minutes. Inflammatory bowel disease, Erb's palsy, and the best way to open is open a book, whichever book you're practicing with, and whatever page it opens, whatever topic's there, try and talk about that for about 2 minutes into your phone and then listen back. I can assure you, you'll be very surprised as to all what you think you have said and how you have said it. In that, introduce a station, how to attempt a station, do's and don'ts for each station, and best practice to score maximum marks. Mini mock, you have had the experience, but basically, we have the candidate or one of you in the hot seat, and by rotation, everybody has to come and sit in And I think some of the candidates find that uncomfortable. But remember, you're going for the exam in which you would be in the hot seat, and it's going to be very, very expensive. Examiner hats for other colleagues so you know how you will be assessed. It also gives you an opportunity to watch your colleagues, and I can assure you the mistakes they are making, you will be making yourselves, and you can only learn from them. We have senior feedback from myself and my colleagues, and then at the end of the day, we have a reflective session as to what you learned during the session. So, a summary is shared with the group and is also put on our website. Thank you. Any questions?
Yes, sir.
Yeah.
Uh, Apart from video station, remaining all other stations, the 4 minute in the 4 minute waiting period, would we would be provided the information leaflet, no, sir?
Usually there is, but I think I will go to Dr. Varsha to tell because I think she's the one who took the exam
Okay.
recently. Varsha, do you get
Yeah.
a bit of information before every station?
Good evening, sir. Yes, sir. No, no, not every station. Clinical station, you won't know where you're going. Once you go there, you will be asked to examine the system. And video, there will be a stem. Before you go inside, there will be a stem for video. Only clinical stations, there is no stem.
Okay. Even
And
for communication,
communication, there is a stem outside.
okay.
Communication, history taking, development, and video. There is a STEM. Clinical station, you are just going to sit there and just close your eyes and relax for a while because when you go inside, you don't know which system they're going to ask. So you should be prepared. There's no STEM.
Okay.
Any other questions?
No, sir.
Okay. Varsha, Sishan, any advice you want to mention? Sishan, you're on mute.
Yeah. Can you hear me, sir? Yeah.
Yep.
Yeah, Leland, if you have any specific questions, it will be easier to answer. But in general, otherwise, uh, stay calm. That is the first thing. You have 2 months for the preparation. So have your, pro forma for each station done, how you will proceed with each station. You have to have that clinical station, how you going to start the examination. That has to be prepared for yourself.
Okay.
Video station and the communication we are practicing. Uh, Otherwise, theory, no much is needed. What you know is enough. So probably practice is very important. So what we do is you need to practice in the next 2 months. Apart from you attending SIRS class, you need to have a small group of yours who's going for the exams. So
Yes, sir.
practicing with them really helps. So
Okay, sir. Thank you, sir.
Varsha, any advice?
Mhm. Yes, sir. Whatever Shishir said, apart from that, examining normal children and children with specific complaints, he needs to go to the hospital and examine them on a daily basis. Time yourself so that you are able to finish it. And for communication, you have to practice in a group of people or your friends or anybody. You just catch hold of them and tell them, I'm going to talk, you please listen. The more you practice, the better for communication.
Okay, ma'am. Thank you, ma'am.
And another bit of advice is use your smartphones. They're very sophisticated. They can do a video recording and an audio. So put it in a stand about 3 or 4 feet away, open the book and then talk. Because your body language, your expression, everything counts, and that'll be the best way to do it.